Hello, my name is Andrew Blaikie. I'm a consultant ophthalmologist from Scotland. Thank you for giving me the opportunity to speak on frugal technologies for eye screening, the Arclight project. The Arclight project is a social enterprise based at the University of St Andrews in Scotland. We enable those working in low resource settings to equip, train and empower healthcare workers to confidently diagnose and manage eye and ear disease using frugal kit. With William J. Williams, an optometrist and frugal engineer, we are addressing the limitations of orthodox diagnostic tools to widen access in resource-poor settings. The first device I am presenting is the Arclight, a direct ophthalmoscope, anterior segment lupinoscope. It uses a radically different frugal design to that of traditional devices, placing an LED light source directly below the sight hole. This reduces cost and size, as well as allowing it to be solar powered. There are 4 price bands depending on the Human Development Index of a country, with a cost of £60 in those with the highest HDI and £12 in the lowest. Despite its low cost, small size and simplified design, many studies have now been published supporting its role as an effective replacement for much more expensive traditional tools, particularly in performing the fundal red reflex test, or, as you call it in the Philippines, the red-orange reflex ROR test. This evidence base has led the World Health Organization to recommend for the first time that eye screening, and in particular performing the fundal red reflex examination, should now be part of the neonatal examination, even in resource-poor settings. This led us to develop a comprehensive package of training tools to implement fundal reflex screening with colleagues from the London School using a USAID grant in Tanzania. This video summarises the content and structure of these materials, which can all be found on the Arclight project website and YouTube channels. Firstly, an overview of the device and how to switch it on and what end does what, emphasising that there are 2 ends, one an anterior segment loop and the other a direct ophthalmoscope. Then an explanation of how to attach the Arclight to the camera of a mobile phone to capture video of clinical signs for teaching and telemedicine purposes. Tips on the assessment of the appearance of eyes and observable visual function are described, including fixing and following faces, returning silent smiles, following lights, and engagement with pictures, as well as assessment of squint and for the presence of nystagmus. Then, the actual technique of performing the fundal red reflex test in newborns as well as older children is shown, alluding to the different appearances amongst babies of different degrees of skin pigmentation. The more challenging assessment of newborns is illustrated, describing the different approach needed to that of older children, such as having to open one eye at a time. The differences in the actual appearance of neonates are also emphasised compared to older children, such as the natural presence of squint. Normal and abnormal reflex results are then shown, including the explanation of the corneal reflection test for the presence of squint. Video examples are shown of specific pathologies such as cataract, retinoblastoma, corneal scar, squint, and refractive error. A comprehensive set of test examples with answers and actions are included at the end. Finally, and very importantly, we made a video that explains how to deliver a workshop using the range of materials we've developed. These materials include posters, handouts, video, simulation eyes, and the Arclight device. These tools can all be used to effectively implement the Arclight at the time of distribution. Training the trainers is an essential part of our work, and the video supports capacity development. Local trainers are encouraged to lead with supervision and explain how to use the Arclight device using videos, posters and handouts. Participants then go on to use the device examining each other, as well as dedicated simulation eyes that we have created to illustrate normal and abnormal findings. The eyes allow for training, then assessment, and generate a fun interactive learning experience, finally finishing with illustrating clinical signs using the Arclight attached to the camera of a mobile phone. And so that's the Arclight direct ophthalmoscope, a cost-effective and simple means to scale fundal red reflex screening in both high and low resource settings. And that brings me to the second device that we hope to release this year. And that's an inexpensive, simplified, solar-powered binocular indirect for ROP screening. The device is very compact and light with a simple elastic headband, and similar to the Arclight direct ophthalmoscope is also solar-powered using LEDs as the light source. The IEPD is fixed, but with a wide optical entrance can accommodate a wide range of IPDs. There's only one control button, which alters the brightness of the light, and overall I found it very comfortable and simple to use, giving an excellent view of the back of the eye. So far there's been one comparative study published in Eye, and this found comparable performance to a much more expensive orthodox spectacle mounted device. To effectively implement the indirect, we have established interactive workshops. When teaching ROP, the three major components of how to describe and identify threshold ROP are emphasised, with case-based discussions systematically going through each step needed to decide if a baby has threshold disease and needs treatment, or can be reviewed or discharged. Videos of real examinations are then showing, relating zones to the actual view seen using an indirect. We also use edited and annotated time-lapse videos to emphasise zones, as well as the development of plus disease, highlighting this is not a binary sign but a spectrum. Use of simulation eyes is essential to training and assessment. We have pioneered a unique goring technique that turns flat 2D retinal images into 3D hemispherical fundi at ultra low cost. Any images can be printed in the eye, such as non-clinical LIA symbols to EDTRS images for diabetes screening or artist-created realistic ROP signs. The printed images can then be cut out and placed into the body of our simulation eyes and used to train and assess participants. These videos show the wide range of ROP signs that can be emulated in the simulation eyes, creating a highly interactive and engaging workshop. After gaining confidence with the simulation eyes, they can move on to examining each other, and through using our teaching mirror, participants and trainers can confirm what each other are seeing. Finally, after the workshop and with ongoing mentorship, expertise in examining adults as well as babies can be developed. And finally, before I finish, I need to thank the wide range of funding bodies, academic institutions, training schools and NGOs that have supported this work over the past decade. Thank you very much for your interest in our work.